This CT scan on the right side shows the presence of soft tissue opacification of the right side middle ear cleft and mastoid. And what you see in this axial section specifically, if you see carefully, is the erosion of the posterior canal wall. You can see a relatively large defect in the middle of the posterior canal wall with complete soft tissue opacification and expansion of the entire external auditory canal, including the anterior wall, which is basically because of the presence of an external auditory canal cholesteatoma. Now, you have to first observe and see by this approach. Our plan is to do a cortical mastoidectomy and a sort of an anterior posterior mastoidectomy. In case the cholesteatoma is not affecting the antrum and the rest of the mastoid air cell system, we would prefer to conserve the canal wall. That could be difficult given the fact that the patient already has a large canal wall defect, which by itself sometimes happens to be an indication for a canal down mastoidectomy. But here in this patient, it is important to make all attempts to preserve natural anatomy, given the fact that he has minimal hearing loss, not much really, and the tympanic membrane is intact, mostly just thickened with a slight retraction posteriorly, but there's no retraction pocket that is deep or any atic cholesteatoma. So essentially, we are fighting a external auditory canal cholesteatoma that has eroded both the anterior and posterior canal walls. The posterior canal wall has a large defect, which needs to be addressed in this patient. So we initiate our surgery by doing a standard cortical mastoidectomy. We have to see what are the contents of the mastoid antrum, that soft tissue opacification that we saw on the CT, if that is really cholesteatoma, or that there is just some edematous mucosa, which could very well be the case. And then that definitely would add to our attempts to safeguard the canal wall and not take it down. So you see, this is standard steps of cortical mastoidectomy. We'll keep on lowering the drill size as we go deeper inside the mastoid cavity and towards the antrum. One must be careful regarding the presence of the sigmoid sinus. Sometimes that is anteriorly positioned, may significantly hamper, and must not be injured. And you mostly notice that we're not seeing any cholesteatoma as such per se inside the mastoid antrum and the mastoid cavity. We can just see overall edematous and inflamed mucosa that is sort of quite hyperemic and bleeds on contact. And for most part, that's a good thing that we have not found any gross cholesteatoma inside the mastoid proper. Now, the endpoint of this would be exposing the posterior epitympanum, that is mostly just seeing the short process of incus and seeing if everything behind that is clean. You'll see we are just removing some mastoid air cells. We need not chase each and every cell here. That's not the point. The point is just to open the antrum, the mastoid air cell system, completely clear it, irrigate it using ample amount of irrigation, and make this patient discharge free. As you see now, the antrum is open. The canal wall has been thinned. And now we resort to a mastoid, to a diamond burr to open the slight amount of the corner septum that you see here anteriorly towards the incus. One must constantly keep looking for the incus short process and not drill the incus short process, because contact of the drill with the incus can lead to sensory neural hearing loss, possibly in these patients, and must be avoided. Also, it's a good point to use a diamond burr close to the tegment dura and the tegment plate, because sometimes the cutting burr can often injure the tegment plate or sometimes the dura itself. It's also important to not excessively thin down the canal wall, because you see it's already, there is a large defect in the canal wall, which we'll probably shortly see, and excessively thinning it may create complications in terms of reconstruction options. Now you see, we've just changed the angulation of the mastoid cavity that we have drilled. The small cotton ball that we have placed here, there's no cholesteatoma. Sigmoid sinus plate can be seen posteriorly. And now we'll see what is the external canal concern. And of course, we have to lift the tympanometrial flap to see the contents of the middle ear as well. You see, this is the cholesteatoma, or the thickened skin of the external canal wall that you see. And now we are carefully elevating it. The entire TM flap from the middle ear to examine also the ossicular status in this patient, because if given a chance, because this patient already has very minimal hearing loss, you would try to preserve the ossicles until it's absolutely necessary to sacrifice them. So now you see that there are granulations on the external auditory canal anteriorly towards the canal side. We are taking a diamond burr to clear them and to create a clean polished bone on the external canal side. Once again, very cautious to not excessively thin or fracture the canal wall, because that would definitely jeopardize the entire procedure. So we're just taking the diamond burr carefully in drilling off the granulations that are there on the canal wall anteriorly. And not, I would say that this is the canal wall defect I was talking about that we saw in the CT. It's a large size defect covered by just some mucosa or granulation tissue like you saw. And you see how this defect is pretty big actually, and would need to be reconstructed in the end once complete disease removal is ensured. Now see, once we put the tympanomeatal flap back just to assess approximately where we are seeing a lot of granulations that are there contiguous with the canal defect that you see here. Now these ones, and these granulations are continuous with the canal wall defect. They have to be removed, and some of them may also be inside the middle ear in the posterior superior region. I mean the posterior superior mesotympanum, which also have to be removed. One thing, everybody who does canal wall cholesteatomas must be very aware that when the canal is expanded because the pressure of the cholesteatoma, or there is bone erosion posteriorly and inferiorly, one must be very cautious regarding the facial nerve as well, because sometimes even the mastoid segment in such patients can be exposed because of the cholesteatoma. The chora tympani can be exposed, and one must be very careful in drilling this the canal side in these patients. We recommend using only diamond burrs and not cutting burrs, and also with our soft tissue dissection techniques as to not inadvertently cut anything till you have made sense of the location of the facial nerve in these patients. So landmarks to locate the mastoid segment are very important. That is the stapedius tendon, the entire posterior aspect of it, the pyramid one has to see and approximately visualize or conceptualize the level of the mastoid segment of facial nerve in these patients, which could very well be jeopardized if anatomical landmarks are not kept into perspective. Now you see here also a word of caution that we are clearing off some granulation of the canal wall defect, but once again every bit of caution is required, because sometimes blindly removing tissue from this place, the posterior inferior region particularly, where the facial nerve can be even lateral to the annulus, could be very jeopardous to the facial nerve outcomes. So one must be very careful in these patients while disease removal. Now see, we are lifting the retracted posterior drum from the middle ear ossicle, that is the incus, and then probably more until you see this, the incus, lifting from the short process of incus. You see how posteriorly pushed is the canal wall. We haven't drilled much posterior superiorly, and you see how much you can practically see the entire short process and body of incus with the amount of erosion of canal wall that you saw. And you see now with the mixture of instruments like iris scissors to a sickle knife, we keep on dissecting the disease and the epithelium, or not the epithelium in this case actually, the granulations and the sort of unhealthy mucosa from the incus and the some portion of malleus as well, because you want to remove all bit of infected tissue that has been discharging for quite some time to optimize the surgical outcomes. Now see how this is the groove between the incus and malleus. Now see, now you've already seen the uh, incus short process, the body, the long process, and now this is the malleus head, over which we are removing the edematous or polypoidal mucosa that was covering. And once again, one has to be very cautious in lifting of this mucosa and not exert too much pressure, because then there's a risk of stapes subluxation given the fact that the IS joint could be expected to be intact in these patients. So, clearing a disease from an intact IS joint is obviously very jeopardous. One can also see the anterior medial ligament there from which the diseased mucosa has been removed. Time and again in these patients, one must put the flap back, reorient, and create a mental roadmap as towards the possible locations of the annulus, the chora tympani, and the facial nerve, because we are operating in a distorted anatomy where the canal wall is grossly expanded and eroded from anterior to posterior, thus compromising landmarks. You see, that is us entering the middle ear and middle ear seems to be clean, and you can already see the chora tympani. See here, that is the chora tympani, and you know where the chora tympani ends. That would be your approximate location of the facial nerve. So this is, assuming that the facial nerve would be just a few millimeters behind the chora tympani. You can already see the approximate chordofacial angle from anteriorly on the canal side, something that you normally see during the posterior tympanotomy from the posterior side. So see, now we'll be just clearing this diseased mucosa with some granulations from the leftover portion of the ossicles uh, for optimizing the graft uptake, as well as the good part is that the middle ear is clean in this patient and there is no cholesteatoma access in the middle ear. So apart from removing the diseased edematous or unhealthy mucosa from the retraction pocket and the epitympanum and the posterior mesotympanum, our focus would then eventually be on the reconstruction of the canal wall and the neotympanum. Now we assess that the oscular mobility seems to be all right. So there is erosion. You can see this the size of defect in the posterior canal wall as we are using our suction to go through that. You see now it's quite a large defect of the posterior canal wall. You see now, and appropriate sized cartilage from the concha would be used to reconstruct this, as well as some portion of the bony scutum, which is eroded because of the disease. And now you see we're just clearing the last bits of diseased mucosa from the long process of incus, which still has contact with the stapedial CP's head, even with some erosion. So we would not want to remove this incus because it is still conducting. And we hope that with disease removal and placement of a cartilage graft, the IS joint intact status would be preserved in the future as well. Now again, this is just using a cotton ball to clear the undersurface of the bony bridge, the bridge that we normally take down using it in a canal wall down surgery. So you can see that how cholesteatoma erodes bone completely. This is just to scrape the undersurface of the bridge to clear any possible diseased epithelium that there could be. So for most part, there is not. This is only covered by granulations. And now you see how it's just taking a lot of time and patience to completely clear the incudostopedial joint of any unhealthy, untoward mucosa or granulations to be very sure that we're not leaving behind disease. So spending some time here could be totally worth it, and some small tags on the IS joint can then be cleared using either blunt or sharp instruments. Now you see we're going to resect the entire bunch of the granulations and the unhealthy mucosa or diseased mucosa that harbors infection before we put the tympanomeatal flap back. That would lead also to a defect, which of course we will bridge use when we use the temporalis fascia for grafting. It can't be overstated how important it is to safeguard to completely clear the diseased mucosa, because that can often have biofilms and chronic infections with these patients and often jeopardize the graft healing outcomes. And normally we always prefer using a sharp dissection here. We'd not prefer or like to pull onto anything, because that creates significant traction, can demucosalize the middle layer, which is detrimental, or by chance these are attached to the ossicles, dislocate them as well. So there goes the tissue, and then some more. So now you see when we put our flap back, post resecting the unhealthy tissue, our TM flap falls back, and now we see you'll be using a full thickness conical cartilage to bridge the defect size in the external auditory canal posteriorly, and this has been approximately sized in accordance with the defect size. It shouldn't be small, it shouldn't be too big. It should be sort of optimized, because if it's too small, it's going to just slip inside the mastoid cavity, leaving the large defect, which obviously would not work out and lead to recurrent cholesteatoma. There is a second piece of cartilage that goes for reconstruction of the exposed scutum that was eroded over the ossicular heads, the incus long process, incus short process, and portion of Milius head, over which eventually we will place our graft. So the graft would go underlay, that is medial to the annulus, but lateral to our cartilage grafts, both the one on the canal wall as well as the one that is there in the posterior epitympanum and superior mesotympanum. Now see that the temporalis fascia has been nicely tucked and now covers both our cartilages as well as the new middle ear, which has been cleaned, over which we will rest our tympanomeatal flap, and that would finish off our procedure for this particular indication in young patients. It's very important to not leave any bare bone on the canal, because that obviously creates a lot of healing problems. So whenever there is bare bone, one must use fascia to cover the bare bone, over which one can expect slow but steady epithelialization. Now you see that the flap has been put back on the facial graft, and this looks like a good assembly, where the disease from both the mastoid and the middle ear has been cleaned appropriately, and we have been somewhat able to preserve the anatomy of both the mastoid and the wall as well as the middle ear ossicles.